So good evening, folks. David Rawson here, president and founder of the Academy, and it's a real pleasure to welcome back to our stage tonight a great friend of our Academy. Dr. Bailey came to us at our last personal in-person meeting. It seems like years ago, but it was November 2019. He's been with us, I think, Dennis, this is your fourth presentation, and we really do appreciate your commitment. And he's going to be speaking tonight on sleep and pain, a bidirectional relationship. And I know he'd be embarrassed if I read his full resume. It's on our website, but there's been an addition to it. And I want to highlight that he's now joined the faculty of the School of Dental Medicine at Lake Erie College of Osteopathic Medicine in Bradenton, Florida. He'll be teaching oral facial pain and TMD, as well as dental sleep medicine. And the second edition of his textbook was released this summer. So Dr. Bailey, welcome back. And we're glad to have you with us and glad you're safe and sound yourself.
My topic tonight is one that is of great interest to me because I started off in the field of dental sleep medicine more on the pain side, oral facial pain, back in the late 70s into the 80s, and then got involved in sleep. So what I want to do is try to bring you the bidirectional relationship that seems to exist based on evidence and based on my clinical experience and expertise. Sleep disorders and oral facial pain are bidirectional. It includes TMD, which is head and neck pain. Most of that is musculoskeletal, not so much the TMJ itself, but mostly the musculature. And there are pain referral patterns that occur with the musculature that then can refer to other areas of the head and mostly the face. Little point of information or review: head and neck are so closely related through the third division of the trigeminal nerve. The fibers of both the upper cervical spine and the third division of the trigeminal coalesce in the Gisserian ganglion or trigeminal ganglion, mostly in the lower portion of it. And so you can have pain from the neck that can radiate to the head and face and vice versa. Neuropathic pain is part of it, related headaches, meaning headaches that have some origin from the cervical spine as well as from the musculature. And there's growing evidence that migraine, for instance, has a cervical component to it. In fact, a recent article in a journal on headache reported that about 40% of all migraine has some type of cervical component. And I suggest to you that maybe we should consider this as sleep-related oral facial pain. Sleep and pain, as I said, is bidirectional to pain and sleep. They impact one another. You can't manage one without considering the other. And that's one of the big dilemmas, is that oftentimes pain is not found in the patients that are coming for sleep problems, and sleep problems are not found in the patients that have pain, who are being treated in, say, pain centers. The question is, which one do you address first? And basically, you want to look at the pain component, typically because it enhances the sleep problem, but sleep disorders will also enhance the pain problems or the pain management. But enhancing the pain problem, oftentimes, as I will show you, can have a great effect upon the sleep. Many sleep and pain aids or medications also address sleep and pain. And I give you two examples here, such as Ambien, which is called a GABAergic medication. In other words, it has a strong effect upon GABA within the central nervous system. Gabapentin, or what's known as Neurontin, is another one, and it can have a strong effect upon sleep. The pain and sleep relationship is known from the National Sleep Foundation. They have a very nice brochure, by the way, on pain and sleep. And then this book that came out many years ago from the International Association of the Study of Pain. Well, now we may have to look at this bidirectional relationship as actually tridirectional, because although it was previously seen as a sleep-pain relationship, now we have to take into consideration, or should take into consideration, anxiety. Because many times with the loss of sleep, the onset of pain, and particularly when the resolution of the pain is not as immediate as the patient would like and becomes more chronic, anxiety becomes a factor, as well as sometimes depression. And so, as Charlie Brown says, my anxieties have anxieties. This is kind of a diagram, and I won't read this, what's on the slide, but you can kind of see how all of these things interrelate: sleep, mood, anxiety, or activity rather, and energy, all centering around pain. And you could say almost the same thing for sleep. So we look at this kind of, or I look at this as kind of a three-legged stool. We have our sleep quality on one side, our painful conditions on another, and mood disorders at the bottom. Well, the actual relationship goes way back into 1900 BC, when in this treatise of Search of Immortality was translated. And as you can see the quote, "My face was not sated with sweet sleep. I fretted myself with wakefulness. I filled my joints with aches." And so there have been reports that go back to ancient times that these were closely related. There is a definition of pain which comes from the International Association of the Study of Pain. 40 years old definition says it's an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. In July of 2020, this definition was somewhat revised. It's still an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. The problem with pain is that you can't measure it. You have to take the patient's word for how much pain they are in. We use a thing called a visual analog scale to try to figure this out, but they're not as reliable as we might like, and one person's interpretation of their pain can vary significantly. An alternate definition, which was published in the journal Pain, says pain is a distressing experience. Pain is an experience associated with actual or potential tissue damage with sensory, emotional, cognitive, and social components. All of these things come into defining the true definition of pain. Well, in dental sleep medicine, this applies more to just sleep-related breathing disorders because it's related to everyday issues. And you may remember I showed a number of evidence-based documents relating to the modern definition or more modern definition of dental sleep medicine, in that it now encompasses or embellishes orofacial pain, TMD, headaches, gastroesophageal reflux disease, and other types of conditions like sleep bruxism. So all of the things that are listed here on the slide all come into play in terms of what we see. And I reference here that exact article, The Face of Dental Sleep Medicine in the 21st Century, published in the journal Rehabilitation a couple of years ago. Defining terms for pain, I want to list these for you. I'm not going to read the definitions to you. I want to call your attention to a few. Allodynia is one, and allodynia is pain to a non-noxious stimulus. So if somebody presses on your face or presses on your nose or your chin, is it painful? And if it is, but it's a non-noxious stimulus, that's called allodynia. Dysesthesia is an unpleasant abnormal sensation. Heterotropic pain is one you should be familiar with because it refers or relates to trigger points in various muscles of the head and neck. It can refer pain to distant locations. It's also called referred pain. Then there's hyperalgesia, hyperesthesia, and nociception, which is just perception, a conversion of stimuli into a neural impulse. So these terms are important to understand when we're trying to define painful conditions. Basic pain perception in the periphery, not so much in the head and neck, but in the periphery, goes through different fibers. So you have A fibers and C fibers. The A beta and A delta fibers are the main ones. They go through the fibers to the dorsal horn of the spinal column and then to higher pain centers in the central nervous system or the brain. The A fibers are large diameter fibers, and they have faster transmission. They're comprised of four types in order of their size, larger to smaller, and speed, faster to slower. They are alpha, beta, gamma, and delta. Now the C fibers are smaller diameter, so they're slower transmission. So in other words, if you put your finger on a hot stove, your A fibers are going to transmit the pain immediately to pull the hand back, but the residual pain from that hot stove goes through the C fibers. The difference between them is that C fibers are unmyelinated. Glutamate is the neurotransmitter. They're associated with dull, aching, or burning pain and an itch sensation. A delta are myelinated. All the A fibers are myelinated. Glutamate is still the neurotransmitter. in A deltas, but not in the A delta, not in some of the other beta and alpha. A delta and C fibers are associated with hyperalgesia, and both can conduct warmth and cold. So the A deltas are your first pain, like I mentioned, where you put your finger on a burning stove or a hot plate and you get that initial sensation. That's the first pain. The C fibers continue the after effect of that as it continues. Pain and sleep, the prevalence, well, this is back from an old paper or an old study in the National Sleep Foundation Gallup poll, but they found that 56 million complain of chronic pain interfering with sleep. They have difficulty falling asleep, and it can also cause awakenings during the night. In solving the sleep pain puzzle, there's a very interesting article from 10 years ago that was published in the Journal of Sleep by Tang and et al. Pre-sleep pain did not predict subsequent sleep quality. So in other words, if you went to bed with pain, it didn't necessarily predict what your sleep quality was going to be, remembering that sleep quality is more subjective. The subjective sleep quality, not subjective sleep or actigraphic sleep efficiency, was the most reliable predictor of pain the next day. And that generally centers around the fragmentation of one's sleep. So the bottom line from the article was improved sleep quality, the perception of that sleep quality, which helps to control or manage the pain. Sleep continuity and not simply sleep restriction causes an increase in spontaneous pain. Another article from the journal Sleep about the relationship of sleep and pain. Number of awakenings or fragmentation of sleep are going to influence pain as opposed to those who are not sleep deprived. There was a paper published in the journal Sleep in 2020, and it talked about medicine during sleep. And the title of the paper, and I've referenced this before in previous talks, was Is it sleep medicine or is it medicine during sleep? You know, we all talk about sleep medicine and about all of the health and medically related conditions that are associated with sleep. But there are some health and medical conditions that are more aggravated during the sleep period or have more of a significant impact on one's health that have a different profile during the sleep period. So is that medicine during sleep? And I give blood pressure as an example. Pain is another example. But as you all know or should know, the elevated blood pressure during sleep is more closely associated with fatal and non-fatal cardiovascular events. Do non-specific diseases occur only during sleep? That becomes the question. Do we have certain diseases that go unrecognized that may actually occur during periods of sleep? Well, I don't want to bore you with the neurobiology. We've talked about this before. I want to go through these quickly because I want to make a comparison to the neurobiology that's out there related to pain, and you'll see the close resemblance. And so this is what gives us this bidirectional relationship. Acetylcholine, GABA, adenosine, glycine. These are 4 typical neurotransmitters or neuropeptides that are responsible for our sleep. And I've shown you or given you the definitions of what they're there for. Neurotransmitters in wakefulness, a whole variety of them, from norepinephrine to serotonin. And by the way, serotonin is also a neurotransmitter of sleep. It's dependent upon the type of serotonin. In other words, there's different subtypes of the 5-HT, 5-hydroxytryptophan, and there's different receptor sites which are receptive to those different types of serotonin that are out there. So you can have serotonin acting as a wake neurotransmitter as well as a sleep neurotransmitter. And serotonin is also going to be seen as an important neurotransmitter for pain. Dopamine, there's acetylcholine again, hypocretin or orexin, glutamate, and we saw glutamate as being the main neurotransmitter for A fibers and C fibers, and then histamine. So when we look at neurotransmitters in pain, we see glutamate, which causes excitation in the dorsal horn and the spinal column. Acetylcholine, excitatory effect on postsynaptic neurons. And then serotonin, as I mentioned before, for endogenous anti-nociceptive potentials, this endorphin analgesia in the central nervous system. In the brainstem, is activated by medications called TCAs, tricyclic antidepressants. These are very popular medications in low doses that can be used for pain management. And we use these a lot in the oral facial pain arena. They have an analgesic effect and they also help with sleep. In the dorsal horn, along with norepinephrine, allows nociceptive pathways to respond to sensory information. Then continued neurotransmitters. GABA is a major one because GABA has been found to be the major neurotransmitter of sleep, but GABA is also a major neurotransmitter when it comes to pain. It's found in the CNS, it comes from the hypothalamus, it has an inhibitory effect upon postsynaptic neurons in the spinal cord, so it can also have an effect in the lower levels of the CNS. Norepinephrine is excitatory in the brainstem and hypothalamus. Most neurons in the locus coeruleus of the pons, they can affect mood. The locus coeruleus is an area within the reticular activating system of the brainstem. Glycine is inhibitory. It's secreted in the spinal cord, also the trigeminal nucleus. Dopamine, histamine, and nitric oxide even play a role in neurotransmission related to the management of pain as it relates to nociceptive transmission and the transmission in the central nervous system between first and second order neurons. So, having said all of that, you can kind of see a similarity between certain neurotransmitters that are for sleep and for pain, and that gives us further substance for this relationship in this bidirectional mode. Sleep disturbances and orofacial pain. Well, this is from the Journal of Orofacial Pain and Headache. 77% had reduced sleep quality. There was reduced sleep associated with depression and pain. Negative effect is related more to reduced sleep quality, also how they perceive their sleep than is the pain. Results, it's important to assess for sleep disturbances in orofacial pain patients, but it's also important to know if patients with pain have sleep disturbances. Fatigue. This was an interesting article just recently published in the Journal of Orofacial Pain and Headache. Fatigue and sleep quality closely related in chronic pain patients. Fatigue in temporomandibular disorder patients is related to poor sleep, depression, and higher pain intensity. And I've always had the way of saying that fatigue is not necessarily the same as sleepiness or feeling tired. Now, there can be some tiredness associated with fatigue or low energy, but fatigue to me is always something that accompanies patients who are more insomniacs than it is patients who say have sleep apnea, where they're more likely to be sleepy. Fatigue is significant in our temporomandibular disorder patients. Patients with chronic pain report fatigue often ignored by clinicians. That's really important because when we start to talk about chronic pain patients and they have a level of fatigue, that generally relates to facts that they're not going to be helping themselves to make their pain less. They're not going to be doing things that they should be doing. And the side effects from medications are not often recognized because that can lead to fatigue as well, such as the tricyclic antidepressants. I mean, they're great medications, but they have a fairly long half-life. And as such, in the morning, patients can feel quite a bit of fatigue associated with the use of that medication. Sleep study findings when pain is present. We typically see less slow wave or restorative or delta sleep. We will see a thing called alpha intrusions, or what's typically called alpha delta sleep. These alpha intrusions are going to fragment the patient's slow wave sleep. We'll see more arousals, we'll see decreases in sleep time, and we'll see increased movement disorders like restless leg syndrome and periodic limb movement disorders and sleep bruxism. Increased sleep stage shifts may also be occurring, and consequently on a sleep study, particularly a PSG, obviously, you may see much more N1 sleep, so it goes from 5% to a larger number. And this is just to remind you what the EEG of sleep actually looks like. And if we're talking about alpha waves, we're looking up in this area here in the drowsy stage. Drowsiness can also be associated with fatigue. And so these alpha waves may spontaneously appear in these delta waves here. And we need to also consider sleep spindles and K complexes. Now, The K complexes actually signal that stage 2 N2 sleep is trying to get into a delta sleep pattern. But the sleep spindle is important because they're inhibitory. And so patients who may have more sleep spindles will not experience as much pain during their sleep, particularly since N2 sleep makes up about 50% of their sleep. Is sleep a vital sign? Well, years ago it was stated as being so. It's not so much looked upon that way because it can't be measured. But sleep problems predisposed to medical conditions and medical disorders may lead to sleep disruption. Patients feel that sleep impacts health and quality of life. Therefore, it becomes HRQOL, or health-related quality of life. And sleep disturbances lead to a lower likelihood of adherence to medication. That's another thing we need to consider, because if patients are having to take something like a TCA for their pain management or gabapentin, they may be less likely to adhere to the medication schedule, and then that just leads to more of a problem for that patient. We know that there's many theories about sleep. This is one where it's unlikely that sleep has no function, but theories of sleep for restorative and somatic growth. Growth hormone is released, the metabolic theory about our metabolism changing, regulating body temperature, and removing toxins generated while awake, a process called glymphatics. But other partial theories look, and I'm going to focus here on neural growth and processing, because of neuronal plasticity, which simply means that our nervous system is adapting to the pain that we have and trying to prevent it from being something that occupies our life. And so neuronal plasticity is how the central nervous system, through those neurotransmitters, adapts to monitoring or managing the pain that we have. And of course, brain development, learning, and memory are all part of that. Well, this is a quote from my colleague Lee Chong at National Jewish Hospital, Dr. Lee Chong. And he says, waking, REM sleep, and non-REM sleep are each states generated and maintained by precise sets of neurotransmitters within specific neural networks of the brain. It's what I went through before with the neurotransmission. He said, consider waking, REM sleep, and non-REM sleep are merely electroencephalographic representations of existence. I think that quote speaks a lot, because that's how sleep is looked at, as being either awake, REM, or non-REM. And these neurotransmitters are all what's responsible for that. Some more stuff on sleep. This was an interesting article in the journal Sleep in 2006, where they found that REM sleep loss was pretty much responsible for hyperalgesia the next day. And they saw that loss of 4 hours of sleep, and specifically REM sleep, led to this hyperalgesia. So the key points is sleep loss, therefore, will increase our response to pain more than just the pain itself, because remember, hyperalgesia is an exaggerated response to a painful stimulus. And medications that impact sleep may actually increase the pain. Common sleep pain conditions can be sleep apnea or snoring, which oftentimes are associated with headache, insomnia, which is associated a lot with myofascial pain or musculoskeletal pain, movement disorders, which are associated with sleep disruption or fragmentation, and many health-related consequences of sleep disorders are related to painful conditions as well. Now, here's an update on sleep pain relationships. I found this article very interesting, published a few years ago. In 44% of chronic pain patients, a meta-analysis found that insomnia accounted for 72%, RLS 32% related to lack of dopamine in the system, and OSA 32%. Intense pain predicts disrupted sleep, more frequent headaches, and more pain in the cervical area. Shorter sleep duration and poor sleep predicted higher morning pain, and chronic insufficient sleep leads to greater vulnerability to chronic pain. And chronic pain is typically pain that's been present for more than 3 months. Well, in 2015, the Sleep in America poll had some interesting findings, and I want to show you just a few of them. If you want to look at the actual report itself, which is quite interesting, you just go online to the National Sleep Foundation Sleep in America poll, and they will come up year by year of all the different polls that they've done. But here's weekly sleep debt by pain type. So if we look at no pain, there's almost no minutes of sleep debt. But here, if it's acute pain, there can be about 14 minutes of sleep debt, and chronic pain can lead to 42 minutes, almost an hour of sleep debt. So the patient now is more sleep deprived. Sleep quality by pain severity. The blue is very poor or poor sleep. The red is fair and good to very good. So no pain, but there's not very much to worry about with sleep quality. But you see fair and good to very good is very good. So we know that when there's pain, sleep quality goes way down. It's at 6%. So here we see mild pain. I'm not going to read you all the numbers. You can read them for yourself. But it's basically saying that the quality of sleep by pain severity, if there's no pain, it's very, very good. We're in good shape. So severe or very severe pain, we see now that the very poor sleep quality goes up. Pain, health, sleep, and quality of life. Again, quality of life is something that really needs to be measured, something that is not really taken into account because different people in different situations will have different quality of life assessments on their own personal beliefs. So percent indicating excellent or very good health quality of life by pain group. And you can see again, no pain, acute pain, or chronic pain. So we see here general health. Well, no pain, 61% feel it's very excellent and good quality of life. Quality of life is very good. Physical health is very good. And mental health is very good. But if we have acute pain, we can see that now general health, perception of it goes down, quality of life goes down, and so forth as we get along in mental health and physical health. And again, you can read these for yourself. And these would be good to look back over after tonight and just review these tables because this is really what's telling us what's going on between the pain sleep relationship. And this is health related quality of life. And we see again, if there's greater than 4 locations for pain. And there was an article in the Journal of Orofacial Pain recently that showed that when patients have orofacial pain, they're very likely to have other painful sites, particularly the neck, although orofacial pain sometimes is considered to be involving the face and neck. And the low back can oftentimes be involved. But when they have more than 4 locations, we see that the percent indicating excellent or very good is not so great in general health, quality of life, physical health, and mental health. So the more locations, the worse it gets for these people in terms of their perception. And then sleep quality by pain location, greater than, more than 4 locations, you see sleep quality is perceived to be worse. That's the mountains in Colorado. That's where I currently am, not in the mountains, but I'm in Colorado right now, visiting family. And this is the wintertime looking over Lake Dillon. Now, part of the problem with sleep and pain is that insomnia is very often, almost always associated with it. So we have to take into consideration and realize how much insomnia plays a role in this. And remember, insomnia will lead to fatigue, the feeling of fatigue, and insomnia will relate to the fragmentation of our sleep or less sleep, and that will increase our pain levels. Most common sleep complaint is insomnia. Sleep apnea is second. Second most frequent health complaint after pain. And patients with insomnia and obstructive sleep apnea have more sleepiness, worse neurocognitive function, and insomnia is comorbid to the pain condition. Insomnia has historically been defined as the inability to get to sleep or stay asleep. Sleep onset insomnia is a real problem, and sleep maintenance insomnia is a bigger problem because people will typically wake up and lay awake for hours. Whereas sleep onset insomnia, we can deal with that a little bit more practically. Often dictates medications that will be used, which is not really a good thing, and can be residual to other managed sleep disorders and mostly overlooked or ignored. It's really a residual situation with sleep apnea quite a bit. Now, this is a diagram from an article published back in 2001. And what it basically shows is the insomnia patient, which is the one in orange, has a greater release of cortisol. Now, cortisol is a wake alerting neuropeptide. It is predominantly released during the morning hours when we wake up. And it's also something that is released during stressful times. Now, I have this belief that stress is something we all live with. We have varying degrees of it, but we all live with it. I prefer to look at things rather than stress. I prefer to look at it as distress. These are incidents or instances that occur that can create distressful situations. Something didn't arrive in the mail, or we had a problem with our automobile, whatever it may be. Distress is more of what we're looking at. But cortisol is directly related to it. And you see how insomnia with the release of cortisol is directly related to the increase in problems with our sleep. Whereas in the control patients, cortisol release diminishes, particularly during sleep. Now, this is an EEG at the top of a healthy person, and we see normal slow wave sleep in the first 4 hours, like we might normally see in a histogram like this. And here we see the EEG of insomnia, and we see slow wave sleep has been radically changed. We see a lot more N1 sleep. We see more awakenings. We see changes in the entire sleep architecture. And so this is something that is akin to what you might see in the histogram of an obstructive sleep apnea patient. Now, this is one comparing a pre-treatment to CPAP treatment, but you can see, look at the REM sleep here, stage one, quite a bit of stage one, as I mentioned before. There's a lot of sleep shifts. Stage two, and of course, slow wave is almost non-existent. Chronic insomnia, over 10% have persistent insomnia. Over 30% of primary care patients experience persistent insomnia. It's well known that many physicians really don't know how to deal with it other than writing scripts for medications. There are great societal burdens, functional impairment, accidents, quality of life issues, risks for mood disorders, particularly depression, and I mentioned anxiety, and higher healthcare costs. Anhedonia is one of the outcomes of chronic insomnia, where we lose interest in pleasurable things, even in hobbies. Comorbid diagnosis in insomnia, we see that psychiatric is very high. Those are the mood disorders like depression and anxiety, hypertension, rheumatoid arthritis, bronchitis, diabetes. And it's well known that insomnia has many of the same health-related consequences as obstructive sleep apnea does. The third leg of the stool, the mood disorders, depression, poor sleep quality, and 90% of those with depression, pain, and somatic symptoms with TMD is a major condition. That was published. And anxiety, high prevalence of insomnia or nightmares associated with stress or more distress. More of the third leg stool, sleep problems and depression. It's bidirectional. People with insomnia at a tenfold increase or risk for increase of depression. People with depression are 5 times more likely to have a sleep breathing disorder. Many times this leads to a misdiagnosis. Others to consider are bipolar disorders, seasonal affective disorders, and circadian sleep disorders. And inflammation may be the common problem, the common factor. Sleep restriction leads to an increase in inflammatory markers. Interleukin 6, interleukin 1, tumor necrosis factor alpha, C-reactive protein, which is not listed. Prostaglandin system is also involved, which has a marked impact upon inflammation, found in sleep disordered breathing, oral obstructive sleep apnea, and insomnia. And what is the most common sleep aid? Well, it's been found that one of the most common sleep aids is actually aspirin. That people will take an aspirin before bed because it helps them to sleep better. Why? Because it probably reduces their inflammation. And what is the role of melatonin that people take? Well, we've talked about melatonin before in some of my other presentations. Melatonin is a very important anti-inflammatory. I mentioned some of these others before. Odds ratios are up there for health consequences of insomnia, just like they are for obstructive sleep apnea. So I'll just leave it at what the data shows here. What's the common denominator in some of these things? It's the inflammation. Sleepless nights are linked to brain changes. This study from China found abnormalities in the white matter, 23 with insomnia and 30 healthy volunteers. The main impact was on the thalamus and the corpus callosum, which is going to have an effect upon pain perception. The longer the insomnia, the greater the changes. Sleep loss in the brain, these are some areas of the brain that can be affected by sleep loss in the parietal lobe, the neocortex, the prefrontal cortex, the frontal lobe, and the temporal lobe. You can look at all of these yourself and what it does, and it disturbs a lot of things like memory, learning, making good judgments, creative thinking, and even logic. Insomnia with sleep apnea, it's a new syndrome. It's been reported that it goes by the name COMISA, comorbid insomnia with sleep apnea. And are patients with insomnia at risk for OSA? Patients with OSA develop insomnia. Do you do a PSG or other testing? Well, a gentleman, a physician, doctor by the name of Barry Krakow from Albuquerque, New Mexico, had a lot of patients coming to him for insomnia. If you look him up on YouTube, Barry Krakow, Krakow, will show you that when he does sleep studies on a lot of his insomnia patients, they end up being diagnosed with sleep apnea. So other treatment is based on the outcome of the sleep apnea treatment. That's the more recent term is COMISA, also known as complex insomnia. 30 to 70% of insomnia patients have suffer from sleep apnea, and 40 to 60 of sleep apnea patients report significant insomnia. So they are comorbid to one another. Another picture. This is Blue Lake in Nelson Lakes National Park in South Island of New Zealand. Visibility of this lake is 230 to 262 feet. It's amazing. Screening. I want to talk a little bit about screening when we're talking about insomnia. When you're screening for patients for insomnia in a pain patient, you can use the Upworth, you can use the Stop Bang, but there are other screening forms. The one that I use the most is called the PSQI, the Pittsburgh Sleep Quality Index. It's been well validated for insomnia and works well with pain patients. I also, at times, will use what's called the BDI and the BAI, which are the Beck Depression and Beck Anxiety Index. These are one-page forms, not many questions, and they really help us to understand if the patient is suffering from these things. There is an insomnia screening form called Insomnia Severity Index. We need to know a little bit about fibromyalgia because if we're dealing with painful conditions and lack of sleep, fibromyalgia is kind of the benchmark by which this all came to light back in the 70s. And we want to evaluate for orofacial pain, TMD, and do a good neuro screening on these patients. Well, let's look at some of this. The Pittsburgh Sleep Quality Index is good for insomnia, especially for pain-related conditions. It evaluates various conditions and sleep over the last month. So it's longer than what's going on just in the short term. It may be a little bit more complicated for the patient to complete, and this is the PSQI form. You can download this on the internet. It's a very easy form to fill out. Sometimes it requires a little bit of coaching to help the patient get through it, especially if they're fatigued or tired. But it is a very good form. And the beauty of it is you can follow the patient's progress by having them fill this out at subsequent visits. Now, I want to digress for a second because I've talked about a lot of psychological things and what's going on. And a lot of times when I refer patients to a psychologist, I make it known that I'm not referring them there because I think they're crazy. I'm referring them there because their sleep deprivation is related to their anxiety and depression. I don't have copies of the BDI and BAI. You can get those online. This is the Insomnia Severity Index, another very easy to fill out form, and it gives you guidelines for scoring the form here at the bottom. So it's a very easy to read and very easy to fill out form. It helps you to determine if someone is at risk for insomnia. This is the new clinical fibromyalgia diagnostic criteria. It's from the Fibromyalgia Network. At the bottom of the form is a website that you can go on, or you can just Google clinical fibromyalgia diagnostic criteria or new clinical diagnostic criteria, and this form will pop up. It's an excellent form that patients, it's 2 pages. I didn't put the back page on, but the front page looks like this. It enables them to pinpoint those tender points and determine what's going on. For those of you who've been around a long time in the sleep field, you may remember the name Harvey Moldavsky. Harvey was a sleep physician. He was very prominent in bringing to light the fact that our fibromyalgia patients had sleep problems. And he really was the one who brought to light about the alpha delta sleep or alpha intrusion that occurred during those periods of time. Sleep and fibromyalgia, as I pointed out, is disruption in the non-REM stage 4, repeated alpha intrusions or alpha delta sleep that could occur. We found low levels of serotonin that were present in the CSF. Uh, the theory sleep disturbance is a factor in causing the fibromyalgia and keeps making it worse. And as you may know, if you've dealt with fibromyalgia patients at all, they have a lot of sleep issues. They have a lot of anxiety issues uh, associated with their disorder. Fibromyalgia is also being looked at in the more recent stages as possibly being an autoimmune disorder. And these are sleep patterns in the fibromyalgia patient. As you can see, normal sleep is at the bottom, fibromyalgia patients are at the top, and you can look and see visually the differences in the sleep profile of these patients, a lot less deep sleep, a lot more stage 2 sleep, and so forth. What are management options for these patients? Well, obviously, if it's a sleep breathing disorder or OSA, we do whatever needs to be done, whether it's an oral appliance therapy, is it PAP therapy, surgery is mostly for nasal breathing to help them to breathe better. There can be breathing exercises, and myofunctional therapy may come into play. For orofacial pain patients or general pain patients and insomnia, sometimes if the orofacial pain patient has a trigger point, injections can be done. Blocks can be done in certain areas to determine, like if they have referral to, say, the teeth, is it the teeth or is it coming from the musculature? One of the injections that I did quite frequently when I was practicing, and will be doing again when I get the clinic up and running at LECOM, is greater occipital nerve blocks. Greater occipital nerve blocks are very simple to do, and given so much pain comes from the neck and the interplay between the trigeminal, third division, and the upper cervical spine, it's a perfect injection to learn how to do. Of course, you want to check with your boards, particularly in Canada, to see if you're not violating something. CBTI, short-term medication use associated with it. What about melatonin? Well, that's something that we have to decide on our own. But CBT, cognitive behavioral therapy, is the key. And it's very important that this be done as early on as possible once insomnia has been uncovered. And it's amazing how many people don't even know that this exists. They think they have to rely upon medications, whether they be medications over the counter, such as Advil PM or Tylenol PM, or maybe a prescription for Ambien or Sonata or Lunesta. CBT can be a major player in getting these people better. Now, that's the other thing. When I refer these people for CBT, I typically refer to someone who's been well trained in it, usually a psychologist. And when I say I'm sending you to a psychologist, once again, they go, "Oh, you think I'm crazy. You just think I can't sleep because I'm crazy." No, no. The CBT is something that they are trained to do. They'll look for other things related to it, and it should help with your anxiety as well. But oftentimes, short-term medication use in conjunction with the CBT is done, and then the medication is dropped off and the CBT is continued. So keep that in mind as a really viable treatment. And other sleep disorders we have to look at is some of the movement disorders like RLS and PLMs. And here I put iron levels because one of the things that's found in the literature is ferritin levels can be quite low in these patients. And once they're bumped up or gotten up to a normal level, normal microliter level, patients do very well. Other considerations, I've mentioned before, the microbiome and the pain, sleep, depression relationship. And there's been an increasing amount of interest that's going on related to the vagus nerve. Vagus stands for wandering. That's what it kind of means. And the vagus nerve, as you can see in the diagram here, is all over the place, and it does a lot of things. And it becomes very important because the vagus, in an afferent way, is the main communicator between the gut microbiome and the brain. And so the vagus nerve is gaining a lot more attention since the discovery of the microbiome, microbiota, and how it affects or is related to the pain, sleep, depression, and so many other things within the human body. Well, one of the things that I think is a good phrase is demand evidence, but think critically. You know, when you work with physicians, they rely very heavily upon evidence. We as dentists oftentimes think more clinically, and we use evidence to support what our clinical judgment is. And Dr. Manfredini, who is very well known in the oral facial pain TMD arena out of Italy, came up with this phrase, and I think it's very applicable. We look at the evidence, but we also look at the patient, we gauge what's going on with the patient, and we think critically about what the treatment may be. Just as a matter of some references, this is the manual TM Disorders by Ed Wright. That's a picture of the second edition of the textbook that I did recently that came out, as David mentioned, in July. This is Dr. Manfredini's textbook, Current Concepts on Temporomandibular Disorders. Very good textbook as well. There's also another textbook I don't have a picture of on oral facial pain and sleep. Incorporates sleep into it is Bell's Oral Facial Pain that was done by Jeffrey Hokeson. It's in the 7th edition now. So we explored just the tip of the iceberg here in terms of what's going on. I thank you for attending.